Now we will move to the second talk by Dr. Nancy. And Dr. Nancy will talk about a very important step, last step in the control of uveitis in patients with cataract surgery, about the post-operative care in uveitic cataract surgery. Please, Dr. Nancy.
Thank you, Dr. سمير. أتمنى ما كنتش طولتوا عليكم، مش هزهقكم مني النهارده. بس I'm going to talk about another topic that I'm very passionate about, and this is the post-operative care in uveitic cataract surgery. So the main thing is when we manage cases of uveitic cataract, I'm trying to move through the slides. شباب قال السلايدز مش بتتحرك. Oh, there we go. So it's very important the preparation of the patient and the preparation of yourself on what we anticipate post-surgery. As I said in the previous presentation, بكونسل العيان كويس قوي إن دي حريقة هنطفيها بكل الطرق وهنجهز ليها تماما عشان to manage the patient's expectations and the doctor's expectations post-operative as well. So we need to anticipate going in anticipating all the inflammatory and non-inflammatory complications that can occur post-operatively with a very structured follow-up plan and monitoring, and we optimize as much as possible the immunomodulatory and anti-inflammatory therapy. So what are the complications, whether inflammatory or non-inflammatory, are we looking forward to, or should we keep in mind? First of all, inflammatory-wise is the post-operative inflammation that's going to be very aggressive in the initial few weeks or maybe few days, with also the risk of CME, which بيفضل قائم معانا over the first ممكن 3 months or more. And usually CME is the leading cause of suboptimal visual recovery in patients with uveitic cataracts. And the non-inflammatory complications include IOP spikes. A patient ممكن you go full on glaucoma بعد كده. You need a glaucoma specialist with you. A PCO early and aggressive, and IOL deposits. That's usually a late post-operative complication. So the early post-operative complications في أول البيريد بتاعت الفولو-up هتكون excessive post-operative inflammation, IOP abnormalities والrecurrence بتاع الuveitis لو كان quiescent, and the late post-operative هنركز أكتر على PCO وموضوع explantation بتاع IOL. We're going to discuss it كده in the end. So in the immediate post-operative period اللي هو أول أسبوع, الpriority الأساسي بتاعنا هو inflammation control. It's the most important, and the red flags are if you have patient that's developing excessive fibrin, hypopian, posterior synechia reformation after you cleared them during the surgery, and you need to distinguish whether this is only related to the surgery or this is reactivation بتاعة الuveitis according to the aggressiveness of the post-operative inflammation. Also, it's very important to address the IOP spikes early, because it can be due to the uveitis but also can be due to a corticosteroid response. And usually for patients that our uveitic patients, we follow them months before the surgery, and we're already aware which of our patients are steroid responders, and we flag them and monitor them very well. Early review in these patients is very important. The follow-up schedule for patients post-cataract in uveitic patients is narrower than the regular cataract patients. So the post-operative visits should be very frequent. Typically, the schedule is day 1, week 1, week 3 to 4, and then 6 to 8 weeks. This is not the case for uveitis patients. Uveitis patients need a narrower schedule. I might see them initially bi-weekly and then every week until I'm comfortable that the inflammation is controlled at a level that can allow the patient to widen the follow-up period. And on every visit, we need to follow them up on the AC activity, intraocular pressure, macula, the OCT. We'll be discussing this in detail, and the IOL position and the presence of new synechia. For the pediatric patients, we keep a closer eye on GIA patients especially. So the anti-inflammatory strategy, and this is the most important, should be modified according to the inflammation and not according to a fixed schedule. So there's no fixed schedule that I'm going to be giving you. We tailor it according to what you see in their follow-up, and it's very important 1, 2, and 300 times that the patient does not stop their immunomodulatory therapy for whatever reason, because sometimes patients think that you're controlling their uveitis and you're going to remove their cataract and solve their problems. This is not the case. The immunomodulatory therapy is essential because this is a chronic disease. So topically, we give intensive steroids every hour, even if the patient is on systemic steroids, and we injected subtenon or subconjunctival at the conclusion of surgery. And cycloplegics is very important for the prevention of formation of new posterior synechiae. And in a study by Cerqueira et al. In Brazil, they suggest that the severity of inflammatory disease should guide the duration of post-operative steroid taper, and as we said, there is no fixed schedule. The schedule is not something to go on by the rule. It's not going to be the do-all, be-all, but it's going to be a rough estimate on how we manage our patients. So in day 0 to 7, the steroid is usually hourly while the patient is awake, and we consider preservative-free if there is also surface disease. When the inflammation calms down, by the second week, we can move it down to every 2 hours, and we do not taper further if there is more than 1+ cell. In week 3, we can shift it to 4 times a day, and then we assess accordingly the AC activity and the intraocular pressure, and then we can go taper further according to the follow-up. By week 4, I'd recommend that we go for an OCT of the macula, so just to make sure that there is no cystoid macular edema that developed. So this is a 45-year-old male patient that's being treated with a case of Hansen's disease for about 15 years, and he presented with progressive visual loss and has been attributed to his cataract, which is secondary to his chronic inflammation. So preoperatively, he was completely controlled for about 3 months, and then post-operatively, as we can see, the severe fibrinous reaction that's present in the AC, the intense topical steroids every hour that allowed for control at the end of about 3 months. So this shows you the severity of the post-operative inflammation that can occur in uveitic patients, and sometimes or not sometimes. أنا usually ببقى إيدي على قلبي لغاية ما الانفلامation ده يهدى خالص. The most dreaded post-operative complication is the disrupted blood-retinal barrier that will result in CME, and this is why we emphasize the importance of an OCT for follow-up. For these cases, we escalate topical steroids, and we put in addition the topical non-steroidal anti-inflammatory drugs that Dr. Samir talked about in detail initially. And we optimize systemic immunosuppression, because this usually means that there is reactivity of the uveitis entity, and we avoid delays in the treatment so we can improve our outcomes. The anti-VEGF does not have a role in these cases because the mechanism of cystoid macular edema is the inflammation rather than prostaglandin increase related to the VEGF. Rather than a VEGF. So there is a number of studies that have been published on the uses or the importance of use of topical non-steroidal anti-inflammatory drugs like the nepafinac 0.1%, in addition to steroid drops that reduces the risk of CME in high-risk patients, and also about the use of difluprednate as the steroid of choice in these cases because it has good penetration to the posterior segment and can be used to control or can aid in controlling the CME, but keeping in mind the IOP spikes that can be the result of the difluprednate. So use it very carefully and do not go beyond 4 times a day. In cases of refractory CME, as we said, anti-VEGF will not be of much use, but an intravitreal, according to this study, this is not what I do. I do not do intravitreal triamcinolone. I agree with Dr. Samir completely about the risk of the IOP spikes. So we usually go for intravitreal dexamethasone, but this usually doesn't occur in the post-operative period if we're anticipating that this is one of the cases of uveitis that will induce or highly risk of inducing CME, including the chronic cases, patients with pars planitis and posterior uveitis. Then we do it usually intraoperatively in the same setting with the implant of dexamethasone with the surgery at the same setting. Nevertheless, this study showed by Thorne et al. Showed that intravitreal triamcinolone or intravitreal dexamethasone is superior to their periocular counterparts when managing cases of CME. As regards the anti-VEGF, as we said, we do not use it because it doesn't have a much role. However, there are a lot of clinical trials that are putting them under study. So we're going to keep them in mind. We're not going to cancel them completely until the clinical trials are underway. They can give us a very good result if they proved effective, if because of the risks, of course, that are associated with steroid injections. So for OCT macula monitoring, it's important to do a baseline or preoperative OCT, as Dr. Samir said, because these cases of uveitis are at high risk of CME, and then you go for one post-operatively at 4 to 6 weeks, and then 3 months because of the risk of delayed or rebound CME at 3 months. And for cases that have high risk of CME like GIA or the pediatric cases, we consider another OCT at about 6 months. And we keep a low threshold if we have visual symptoms or a visual acuity that is not explained by the clinical picture. And this is, of course, again, we emphasize it a lot with cases of GIA uveitis, but also in cases that had history of uveitic CME, patients that are aphakic or had some sort of posterior capsular compromise, and those with poor inflammatory post-operative control. Other complications other than the big two, the inflammation and the CME, is posterior capsular opacification, and this is actually the most common post-operative complication of cataract surgery in uveitic patients, and sometimes they develop these IOL deposits at the back of the lens as well. The persistent inflammation or recurrent inflammation can happen in 51% of the cases, that there is a kind of a permanent break of the blood ocular barrier, and then there will be always some kind of subclinical inflammation. We have also to know that these patients are highly vulnerable to IOP variations, ranging from the IOP spikes going straight into glaucoma or going the other way into chronic hypotony, and this needs to be managed very closely and very surely and aggressively for the possible risks of such cases. So in special situations, as we said, the high-risk groups, whether in the pediatric age group, that's GIA, or in the adult age group with the two scary entities that we all hate seeing in the clinic, Behçet's and VKH, we consider a prolonged steroid taper. We taper the steroids very slowly, of course, keeping the eye on the patient's systemic condition and his IOP. Early systemic escalation, if needed, of his immunomodulatory therapy, and of course a multidisciplinary approach between yourself and the rheumatologist, because the teamwork is very essential in these cases. The last thing is explanting the IOL, or always keep explanting the IOL an option. Do we often need it? No, it's rarely needed, but if you find that the patient has a perilenticular membrane or the inflammation is too aggressive, it's not being controlled with anything, and not responding to any of the anti-inflammatory therapy, if a cyclitic membrane develops, then the patient has to, or yourself and the patient, we have to agree that this IOL has to be removed. And this is also common with cases of GIA, but also with cases of pars planitis and sarcoidosis, but especially patients with an aspect of intermediate uveitis, whether alone or those as a part of panuveitis. So the take-home message is surgery ends, but the inflammation management does not end. Actually, the uveitis specialist role starts to be serious right after the surgery, and this is when the most effort has to be done. Aggressive control is essential with all the means, topical, systemic, everything. In uveitic surgery, OCT is not optional surveillance. It's very important for disease monitoring, and it's very important, as we said, that the real work starts after the operation. Thank you very much.
Okay. Thank you very much. Thank you very much, Dr. Nancy, for this very nice, comprehensive talk. I think we have like 15 minutes for discussion. هو الحقيقة موضوع الكاتاراكت في اليوفيايتس موضوع صعب جدا وشائك، زي ما حضرتك قلتي برضو. هي الرحله بتبتدي بعد العمليه ورحله طويله قوي، وبنبقى دايما يعني بنبقى ماشيين على صراط كده، على خط مش عارفين برضو نحيد عنه. بنعالج حاجه نلاقي حاجه تانية تبوظ. يعني lastly in the 2 or 3 weeks ago we have a neurosurgeon from Aswan, and we did a very neat cataract surgery for him, وكان presumed to be viral, وخد البروفيلاكتيك انتي فيرال ثيرابي، والسيرجري كانت كويسه قوي. بس انا فضلت ان انا اديله، شفته تاني يوم بوست اوبرتيف كان عنده الانفلاميشن سيفير، فاديته توبيكال ستيرويدز very intense. After 3 days he came to me with corneal edema with high intraocular pressure. So احنا لازم to keep an eye دايما على كل الحاجات دي. فهي الفكره برضو الانتراocular pressure دكتور نانسي. So do you routinely prescribe anti-glaucoma medication in your cases post-op, or it depends?
In the early few days, according to the IOP, so I don't put it directly after the surgery for the fear of hypotony, but usually at the first week أول ما الانفلاميشن عادة بيشد على ثالث يوم كده، نلاقي شدة حصلت فساعتها بحط لهم بقى ال IOP، بس مش first day، يعني مش first day. If Dr. Amgad you do a different routine.
الفكرة بس ان معظم الحالات اليوفيتس دي احنا بنمشيهم في الاول على سترونج ستيرويد زي الدايفلوبريدونيت، ده للاسف مع الفريكونسي العالي بيرفع الاي او بي، فانا بفضل بصراحه ان انا امشي معاه على طول انتي جلوكوما ميديكيشن.
هي نقطة مهمة برضو، نقطة دايفلوبريدونيت، يعني I have a very bad experience with that، يعني لأنه العيان اليوفيتس متعود ياخده very frequent ومش هياخده على 4 بس، وأتصور برضو إنه حتى على 4 لازم to keep بيعمل spikes. So it is not the drug of choice for cases of uveitis despite its being strong and can penetrate.
على ذكر الدنيا لما تهدى بس يحصل مشكله، كان في برضو عندي بيشنت من 4 شهور كده عملت لها كاتراكت سيرجري في عينها اليمين، و ستريت فورورد سيرجري كله تمام، انفلاميشن ولع، مع ان احنا كنا كنترولينج فور 6 months بري اوبراتيفلي، انفلاميشن عدى جلوكوما. what do you do in these cases يا دكتور امجد؟
هو السؤال هل هي معاها بريفرا انتيرو ساينيكي ولا لا؟ لو ما فيش بريفرا انتيرو ساينيكي I will go for untraditional جلوكوما سيرجري اللي هي ترابيكولوتومي. هنفتح الانجل، وده هيفيد بعد كده عشان هي هتمشي على ستيرويد.
برضو بذكر الجلوكوما، لانه دايما احنا حالاتنا بتبقى ميكسد جلوكوما وكاتراكت، احنا بنقول الرول ان احنا تو ويت 3 months اتليست في الكاتراكت سيرجري. هل احنا لازم نعمل ده في الجلوكوما كمان دكتوره نانسي ودكتور امجد؟
هي دي المعضله اللي ما بيننا بقى وما بين دكاتره الجلوكوما. لان احنا بنبقى عايزينهم يدخلوا على طول، واحنا عارفين ان هي uncontrolled ان احنا هنفقد العصب، وهم برضو عندهم حق، هم خايفين من الانفلاميشن لان طريق شائك يعني. how do you convince او what do you do دكتور امجد في الكيسز دي؟
برضو انا ليا تعليق، ومش عارف الملاحظه دي عند حضراتكم ولا لا، بس البيدياتريك جلوكوما عموما في اليوفيتس البيشنت كان ويذستاند هاي انترا اوكا بريشر فور 2 to 3 months. دايما بفحص لهم العصب البصري والاقي الاوبتيك نيرف فيري هيلثي، فاي كان ويت ماشي، ومعظم الحالات بتتحسن بعد كده يعني من غير جلوكوما سيرجري. في الكبار لا، يعني في الكبار ممكن بروسيد وذ جلوكوما سيرجري على طول.
هو برضه هي دي ملحوظه مهمه جدا فعلا، الاطفال بتولريت يمكن elasticity of the tissues we don't know. فعلا بتلاقي الطفل جاي بقاله شهرين he didn't show up والانتراكولار بريشر 40 والعصب كويس، فهي دي برضه they are fortunate for this. هي الفكره برضو فكره الكنترول بتبقى صعبه جدا، لان احنا عندنا حالات، يعني انا عندي حالات بتاخد 4 ميديكيشنز وسيدا ماكسيمم دوز والانتراكولار بريشر مش بيقل. فدايما الدكتور برضو بيسالني هل هي كويت ولا لا، يعني برضو هي بتبقى ديبيت، بس اتصور ان هو اعتقد ان هو لازم يدو سيرجري، لان احنا حتى even with maximum medications with oral Sidamex they are not decreasing يعني. فبرضو بتحتاج، بس اتصور برضو انه بعد الجلوكوما سيرجري الانفلاميشن ما بيبقاش ذات هاي زي الكاتراكت، مش في عنف الاي بالظبط كده.
لو هي هتبقى من غير اي او ال امبلانتيشن مش هيعمل ميكست ترابيكيلاكتومي مثلا او فالف واي او ال، بيبقى الانفلاميشن فعلا اهدى بكتير. separate question بقى في البري اوبراتيف، هرجع في الاول. بيجي لي بيشنتس كتير عندهم كاتراكت، حد شافهم قال لهم عندكم كاتراكت ولازم تعملها دلوقتي، واحنا عارفين ان الثريشولد بتاعنا في الفيجوال اكويتي ليه حد معين، يعني لو البيشنت شايف كام يا دكتور امجد you will not go for surgery، ودكتور سمير او امتى لما الفيجن يوصل كام تقول له لا ده significant وندخل، ده provided ان البيشنت جاي لك اصلا لسه بادي الرحله من الاول يعني.
في قاعدة visual acuity better than 6/12 don't touch. لا انا اسيب البيشنت بالاكوموديشن بتاعه وعارف يقرا احسن ما اعمل له كاتراكت سيرجري. مش عارف الدكتور سمير اتفق معايا ولا
انا موافق حضرتك تماما ويمكن اقل كمان. يعني انا عندي patients مثلا بيبقى شايف، هو depends على اللاتراليتي طبعا، it goes without saying. يعني لو هو بيشوف 0.4 انا ممكن اسيبه، لو 0.4 في العينتين وشايف كويس وايكوال ممكن اسيبه، لان هو يعني performing his duties and tasks وما عندوش اي اشكاليه خالص، ما فيش element في امبليوبيا. لكن امبليوبيا بيبقى الموضوع مختلف شويه، لانه فعلا ساعات بيبقى في عيانين ما بنقدرش نحسنهم اكتر من كده. يعني في عيانين بيبقى عندهم significant cataract وبندخله العمليه وبشايف 0.4 وبعد ما تعمل كل الاجراءات والاي كويت بيشوف 0.4 برضه. يعني هي بتبقى كده.
another question، عشان كان عندي برضو حالة interesting كده لسه من اسبوعين 3. كان عندي patient TB uveitis وكان متابع معانا بقاله 4 سنين واخد العلاج ساعتها وبقاله 4 سنين completely quiescent، وعايز يعمل completely quiescent off treatment، مش ماشي على اي حاجه ولا حتى topical steroids، وكان عايز يعمل الكاتراكت اللي هي بقى لها 4 سنين دي في العين اليمين. In my head I thought this patient is off treatment بقاله 4 سنين، هو كان TB uveitis، there's no need for pre-operative steroids. خلاص ودخلناه surgery went well straightforward، مش عارفه ايه، post operatively severe inflammation. ف how long يعني were you ever faced with cases like this quiescent off treatment خالص بقالهم كتير وراجل كبير يعني عدى المرحله دي؟
حضرتك تقصدي بخصوص التي بي يعني ولا بخصوص الريكارنس افتر
after being quiescent for a number of years
off treatment after and the surgery was done 4 years ago? Yeah, it's interesting really, but I think it may be something maybe not related to the surgery itself, maybe the natural course of the disease, the changes in the weather. As you can see, some of these are seasonal. I'm not sure if it is an active TB or not, so it's difficult to yeah. Yes, this is yeah. احنا دايما بنقول يعني اليوفيايتس يعني عالم غريب ومفيش تكست بوك الحقيقه، ومفيش حاجه تقدر توصف كل الحاجات، وحتى الانتيتي الواحده في الديزيز الواحد بيبقى فيها برزنتيشنز مختلفه وبيهيفير مختلفه. دي طبعا بتبقى حاجه صعبه جدا يعني. بتصور لو في عندنا اي اسئله من الاودينس، حد من الزملاء عنده اي اسئله؟ Okay. So I think by this we covered alhamdulillah most of the aspects of the cataract surgery in uveitis. We hope next time inshallah in the Azores we'll cover the refractive surgery in relation to uveitis. I would like to thank Professor Amgad Norashi and Professor Nancy. Thank you very much. Thank you.